The STAAR Surgical Toric IOL procedure. I'm Dr. Mahootchi from the Eye Clinic of Florida. The STAAR Toric IOL corrects astigmatism at the time of cataract surgery. Today we'll look at the technique of implanting and aligning this lens. I'll also give you my pearls from my now 12-year experience with this lens. About 1 in 5 cataract patients have clinically significant astigmatism. Correcting that astigmatism gives patients better vision without glasses afterwards. In one procedure, you can reduce their astigmatism and the disability of cataract simultaneously. The lens is easy to implant, easy to align, and it satisfies patients easily. To get the best results, surgeons should formally evaluate the accuracy of the refractive outcomes and determine their surgically induced astigmatism for their non-toric cases before they start. Your STAAR surgical representative and the Previse tools on the STAAR website are great resources for this. Once you've determined the axis of steepest keratometric astigmatism and factored your surgically induced astigmatism, you are ready to pick a target axis for the lens. The lens has marks to align with your steep target axis. The lens is designed to stay in place, especially after the anterior and posterior lens capsule fuse through the large positioning holes seen here. These holes are larger than the fixation holes seen of plate haptic lenses of the early 1990s. One of those smaller holes is seen here. Lens rotation and dislocation after YAG were reduced by making the fixation holes larger. There are 3 steps to aligning the lens in surgery. First, preoperative reference marks are made so you know where the 90-degree or 180-degree axis is, or the 3, 6, 9, or 12 o'clock position is, in the natural head-up position. Next, intraoperative goal marks are made on the steep corneal axis so you will know where to align the lens while the patient is lying down for surgery. And finally, you'll align the lens to the goal axis mark. Here my patient is ready for his preoperative reference mark on the day of surgery. We're using the slit lamp of my YAG laser in the surgery center to guide us. The reference marks are very important because once you get into the OR and the patient lies down, finding where 0, 180, or 90 degrees can be very difficult due to cyclotorsion of the eye with block, cyclotorsion of the eye when lying supine, loss of landmarks with subconjunctival edema or hemorrhage, and skew of the patient's head when under the microscope. Here the patient is lying straight, but occasionally the patient will be lying skewed, and this can confuse you where you need to put the toric. Here the patient's head is skewed or his body is tilted, not parallel with the bed. You can use the slit lamp for your preoperative reference marks, and here I'm having the beam aligned vertically. It's important that the table be level. If your table isn't level, the slit beam won't be level. So we ask the patient to look at us and nod off to the side. So, sir, you're looking off to the side. Can you look back at me? And now he'll be looking straight back at me, and I can make my mark. Thank you. Make sure the beam goes through the pupil and not the geometric center of the cornea. Use the vertical or horizontal beam of your slit beam as a guide to place your mark with a suitable marking pen. I recommend marking more than 1 reference point. 2 reference points are better than 1. Before you make your mark, make sure the patient's head is level in the machine. Here a patient demonstrates a right head tilt and now a left head tilt, so the horizon mark will be incorrect if marked in this position. Here he's in the correct position and ready to mark. Although more expensive methods exist like photographic, computer, and laser alignment, I haven't found the need to use them. This helps keep my costs down and allows me to offer the procedure at a competitive cost. Once you're in the OR and have decided you have the correct patient and the correct procedure on the correct eye, you can confirm that you have the correct lens. Here I've picked an 18 power lens with a 2 diopter astigmatism correction for this patient with some against the rule astigmatism at axis 10. I'm sitting temporal to the patient, so my view of the cornea will match this view of the topography. I've set my astigmatism marker for axis 10 degrees. Be sure you use a good quality marker with a bevel that isn't too loose. You don't want to set it and then have it move by the time you make your mark. Under the microscope in the OR, you can see my preoperative violet colored alignment marks at the 6 o'clock position on the right and the 12 o'clock position on the left. I aligned those 2 marks with the 90-degree axis marks inferiorly and superiorly with my marker. Here the bottom of my Dell marker is seen, and you can see the part that makes the impression marks. This is useful since in the rare case that you could not use a toric, an LRI could be safely made. So here we are at step 2. The marker is lined with the reference marks. I press down, and I've got my axis marked at 10 degrees. From this point, you can use your standard cataract procedure. For me, I make 3 small peripheral stab incisions called Wong incisions to help me hydrate and close the main wound at the end of the case. Here we go with those 3 stab incisions. I used that same blade for my paracentesis. It's a specially made diamond blade with a longer angle at the top so I can make both wounds with the same blade. When analyzing different components of my procedure, I found that using diamond blades gave me less surgically induced astigmatism and more consistent results. So that's what I use. So I'm filling the eye with viscoelastic. I'm going to make a 5.5 millimeter round capsulorhexis, not too big and not too small, as to avoid capsule phimosis down the road. Making a consistently sized rhexis each time helps you tighten your refractive results, so take advantage of that. Now that you've successfully done the first 2 steps, the preoperative reference mark and the intraoperative alignment mark, you can proceed with whatever technique you like. I'll take this moment to comment that a lot of little errors can add up to a big error later. Just as head tilt can lead to error when making reference marks, the same head tilt can lead to picking the wrong axis or measuring the wrong steep axis when your techs are getting Ks or topos or IOL masters. Be sure they take note. I also like to use several different instruments when determining where the steep keratometric axis is. I don't just use one instrument. I'll use the IOL master Ks, the topography, auto, keratometry, all those things. So now that you've removed the cortex, use the INA tip or capsule polisher to polish both the posterior capsule and the backside of the anterior capsule. Now I fill the bag with viscoelastic and I'm ready to inject the lens. A good pearl here is to bump the lens in with tiny pushes and plan to pull back on the plunger a bit after each bump to make sure it isn't overriding the lens. The lens goes in easy in this film because it's relatively low power. I'll use a Sinskey to align the lens into the correct axis. I inject with the lens alignment marks on top because it's easier to rotate the lens this way, either now or later. I haven't found that injecting it with the toric marks down makes the lens less likely to rotate, but some have. You should evaluate how variations in the technique work in your own hands. For lenses over 24 diopters, I widen the internal part of the wound so I don't stretch the wound or compress the lens too much. Here you see the lens alignment marks on the lens are aligned with the lens alignment marks on the cornea, and the lens is in the right place. You can then use the INA to remove the viscoelastic. I'll usually press down on the lens to get the viscoelastic out from behind the lens. Others will go behind the lens, but I haven't found the need to do that. It's a good idea to recheck the alignment when you're done so you make sure you haven't moved anything around during INA. And it's also a good idea to make sure you leave the eye a little bit soft and make sure you don't overinflate the eye. Here, I'll hydrate my 3 Wong incisions and the main wound and the paracentesis. So again, some steps to avoid rotations on day 1 is to not overhydrate the eye at the end. Don't overinflate. Make sure you leave the eye a little bit soft. Also make sure you polish the underside of the anterior capsule because although the lens is where you want it most of the time on day 1, you'll need to, if you need to reposition the lens, it's a lot easier to do if the capsule is less stuck together. I advise checking your cases on day 1 and confirming alignment. Mine are correctly positioned 95% of the time using this technique. If you need to realign or reposition the lens, which I do in the office, wait to realign the next week, but not 2 weeks later. The reason is that the capsule is just the right stickiness at 1 week to be easy to open, but not too loose to have the lens rotate again on its own. If the lens is aligned at day 1, you don't have to worry about it rotating. I've only had 2 lenses in the last 1,000 rotate if they were aligned at day 1. The STAAR Toric is very cost competitive compared to other options for astigmatism correction. It's a great value to patients. It's been easy to convert my patients with cataract and astigmatism to it. About 99% of them do. I only average 1 patient rejection of the option each year for the last decade. And about 20% of my cataract patients have enough astigmatism to get offered the STAAR Toric, and that's in line with the incidence of astigmatism in the general population.